Then start the recording, then hand over to you, ma'am. This is Ranjit Sahu, Marketing Head of Walter Busen, welcomes you all to a live webinar on a very important topic, that is emerging role of estrogen in clinical practice. Today, we have with us an eminent speaker, Dr. Dhwani Bhandari. She is a consultant of Skyni from Baroda, Gujarat. Hand over to you, ma'am, to take it forward. Is all yours, ma'am.
Good afternoon, everybody. Thank you so much for the introduction. Now, I will not waste much of our time and will proceed on the topic, which is emerging role of estrogen in clinical practice. All right. So let's start the presentation. So we all know about two main hormones of a female body. One is estrogen and another is progesterone. Am I audible?
Yes, ma'am, you are audible, ma'am.
Yeah. Okay. So what is estrogen? Estrogen, the name comes from the Greek, which means gadfly. But
ma'am, you have not shared the slide, na, till now?
No, I have shared slide.
No, ma'am. The slides are not coming in the screen.
Okay, okay. Let me do it again. Share screen.
Make it to the first slide, ma'am. Make it full screen.
Okay, so this is
yes, ma'am. Now it is clearly visible. Please go ahead.
Okay. So today our topic is emerging role of estrogen in clinical practice. So we all know about two main hormones of female body. One is estrogen, another is progesterone. Ample of knowledge about the progesterone, but very minimal knowledge about estrogen. So here I am with the estrogen hormone, why it is important in our body. So the name comes from Greek, which means gadfly, figuratively sexual passion or desire, and the suffix "jan", meaning of producers of. So the overall, it is a producer of sexual passion or desire. The whole meaning of the estrogen is that, right? So it's an 18 carbon atom steroid, and there are a family of related molecules that stimulate the development and maintenance of female characteristics and sexual production. So this is the history of estrogen. It is little interesting that initially the estrogen was found not directly but indirectly via so many of scientists who promoted the ovarian transplant and saw the results of it, and thus by ovarian transplant or doing anything else, they saw that estrogen is in those patients where we don't have estrogen, they got the effects of estrogen. This is how the estrogen is found. So in 1900 initially, the NOR found that the ovarian transplant prevents the gonadectomy, and then in 23 Allen and Doisy devised a bioassay for ovarian extract. And in 1925, Frank and associates detected an active sex principle in the blood of sows. And in 1926, the Law and Lange discovered that a female sex hormone varied throughout the menstrual cycle and found that it is an estrogen. So in 1928, Zondek reported the excretion of estrogen during pregnancy. And in 29, estrogen crystallized by Butenat and Doisy. In 1941, the FDA first approved estrogen therapy for menopausal symptoms. This is how the estrogen is found. So, three types of estrogen in our body. One is estrone, that is E1. Second is estradiol, which is most common type of estrogen in childbearing age, which is E2. And the third is estriol, that is E3, which is the main estrogen in pregnancy. So E1 is the only estrogen in your body makes after menopause. So in menopausal patient, post-menopausal patient, there is only one, which is estrone, E1. Estradiol during childbearing age and estriol E3 during pregnancy. Okay, so this is a life cycle of estrogen. Mean levels of estradiol, that is E2, increases across the pubertal development until menarche, and when estradiol levels stabilize and then cycle regularly through the menstrual cycle each month. During late perimenopause, concentration of estradiol falls markedly from its elevated levels present during the early perimenopause and eventually begin to stabilize. This is the graph which shows the levels of estradiol maximum during the childbearing age. So this is how estrogen is synthesized. Mostly it is synthesized in the granulosa cells, and it gets converted from androgen to estrogen, which we can see in this graph. All right. So this is the distribution of estrogen receptor in our body. So there are two types of estrogen receptor: is ER alpha and ER beta. So ER alpha mainly present in uterus, liver, kidney, and breast, and ER beta, which is mainly seen in brain, bone, urinary tract, and vascular system. ER alpha plus beta both are seen in some organs, which are ovary, uterus, breast, cardiovascular system, and brain. So, how does the estrogen play the important role in woman health? In brain, estrogen helps in maintenance of body temperature and it delays the memory loss. In breast, estrogen prepares the gland for future milk production. In ovaries, estrogen stimulates maturation of ovaries. And in bones, estrogen helps to preserve the bone density. We all know about it. In heart and liver, estrogen helps to regulate liver's production of cholesterol, thus prevents buildup of plaque formation in coronary arteries. And in uterus, estrogen stimulates proliferation of endometrium. In vagina, estrogen helps in maintain lubricated and thick vaginal lining. So what can go wrong with estrogen levels? If we can see in some women there is a low level of estrogen. So for maybe because of the early menopause or maybe the surgical removal of ovaries. So symptoms of low estrogen include menstrual periods that are less frequent or may stop, hot flashes, a sudden feeling of very warm and night sweats, trouble sleeping, dryness and thinning of vagina, low sexual desire, mood swings and dry skin. Some women get menstrual migraine, a bad headache right before the menstrual period because of the drop in the estrogen level. So in men, if you see the low estrogen level can cause excessive belly fat and low sexual desire. So in what are the symptoms of high estrogen level in women and men? In women, the excess estrogen can cause weight gain mainly in your waist, hip, and thigh. Menstrual problems such as light or heavy bleeding, the worsening of premenstrual syndrome, fibrocystic disease of breast, fibroids of uterus, fatigue, low sex drive, and feeling of depression or anxiety. In men, if the high estrogen is present, they can cause a gynecomastia, poor erections, and infertility. Now, estrogen in clinical practice. What kind of estrogen do we use in clinical practice? This one is a natural estrogen, which is estradiol valerate or estradiol hemihydride, which is mainly used in endometrial preparation in infertility cases and postmenopausal therapy. Now, another is a synthetic estrogen, which is ethinyl estradiol. So its use is mainly in hormonal menopausal therapy, MHT, or contraception. Third is equine estrogen, which is conjugated equine estrogen, which is mainly used in hormonal menopausal therapy. So estradiol hemihydrate, this is a comparison between estradiol hemihydrate and estradiol valerate. Now estradiol hemihydrate is estradiol is associated with a half molecule of water, which is hemihydrate. So the name itself suggests. So it's not a product, it is natural and endogenous estradiol, and it is very potent estradiol. While estradiol valerate is a prodrug of estradiol, esterase in liver decomposes estradiol valerate into estradiol and valeric acid. Further decomposition of valeric acid through beta oxidation leads to C2 units and results in CO2 and water at the end product. So physiological dose comparative efficiency of different kinds of estrogen. So these are the comparative dose of different kinds of estrogen. So 5 microgram of ethylene estradiol is comparable to 0.625 milligram of CEE and 1 milligram of micronidase 17 beta estradiol and 1 milligram of estradiol valerate and 0.05 microgram of transdermal estradiol. So nowadays, we also know that there is a micronization technology which is used in the production of estrogen, estradiol, and why it is important. Micronization is a term used to describe the size reduction technique where the resulting particle size distribution is less than 10 micron. Now, poor water-soluble drugs such as estradiol has a limited dissolution rate and bioavailability. So, micronization results in increased surface area, which is a promising approach to enhance dissolution rate and thus the bioavailability. Now, micronized estradiol comparison with non-micronized estradiol. So, the 15 women randomized control trial were given, and they were given estradiol for 21 days. Randomly they were given micronidase and non-micronidase estradiol. So results, as we can see, high serum concentration of estradiol with micronidized estradiol compared to non-micronidized estradiol. Area under the curve was significantly higher with micronized estradiol. So during treatment with 2 milligram micronized estradiol, the serum concentrations are significantly higher than with 2 milligram of non-micronized estradiol. So micronized estradiol versus another reference in which we can see that micronized only natural unconjugated estrogen. We will further go into detail one by one of these headings. So first is endometrial preparation in ART cycles. Endometrial thickness is very important. It is called as thin if it is less than 7 or 8 millimeter. So, if an endometrial thickness is less than 7 millimeter, it is associated with lower implantation and pregnancy rate as compared to endometrial thickening of 9 to 14 mm. So, what are the effects of estrogen on endometrium? It regenerates the functionalist layer and proliferation of gland, stroma, and endothelial cells. Now, celiogenesis, appearance of ciliated cells around the gland opening, is also stimulates that. It also produces cytokines and other factors which are immune tolerance towards the fetus, and also induction of progesterone receptor. So, is why we can see say that estrogen is a key for the pregnancy will stimulate the dendritic cells, neutrophils, natural killer cells, macrophage, monocytes, beta cells, and regulatory T cells, and all of them together will produce the cytokines, which are the interleukin 10, interleukin 4, interferon gamma, and miRNAs and antibodies, induction of many genes and other estrogen receptor coactivators, which helps in immune tolerance and successful implantation of fetus. Now, clinical experience with micronized estradiol valeric tablets in endometrial preparation. Mainly, our aim is to determine the efficacy of micronized estradiol valeric in improving endometrial thickness in women undergoing donor egg IVF. So, as we can see, our main parameter is endometrial thickness, endometrial pattern, dose of estradiol valerate, which vary in different patients, and number of embryo transfer and number of positive beta HCG results. So, clinical pregnancy rate is at 54% and live birth rate is 42.8% in patients given estradiol. So, the oral estradiol valerate appears to be effective in endometrial priming in women undergoing donor egg IVF with fresh donor oocyte as well as in those undergoing frozen embryo transfer. Now, the second heading, the role of estrogen in luteal phase support. We all know about progesterone, but few of us doesn't know about the estrogen. So, corpus luteum produces both progesterone and estrogen. So, luteal gap occurs in the end of the effect of exogenous HCG and onset of endogenous HCG production. Luteal phase support must be provided during this gap. So, estrogen supplementation to progesterone as a luteal phase support in patient undergoing IVF. So this is systemic review and meta-analysis. This is a meta-analysis of 11 studies which included 1,756 subjects. All of them were given P plus E, that is progesterone plus estrogen. And the results are no significant difference between the two groups: ongoing pregnancy rate, fertilization rate, implantation rate, and miscarriage rate. But neutral phase support for assisted reproduction system review says that the authors analyze the outcome on the basis of estradiol route of administration. Routes of estrogen administration were oral in 6 RCTs and transdermal in 2 RCTs and vaginal in 1 RCT. No difference in the live birth or ongoing pregnancy were found uh, in the different route of administration. The clinical pregnancy rate in studies using transdermal estrogen, a higher pregnancy rate was reported in the progesterone plus estrogen group. So, what is the dose? The dose is the oral, that is 2 to 6 milligram per day. Transdermal, that is 100 gram every 2 days. We get usually these transdermal patches. Vaginal is 4 to 6 milligram a day. So no evidence of difference in live births on or ongoing pregnancy rates between a low or high dose of estrogen. It is 2 less than 2 versus greater than 4. So there is still controversy in types of hormone used in luteal phase support as well as their dosage, duration, and timing. Thus, the role of estrogen along with the progesterone luteal phase appears to be only in those cases where GnRH agonist was used instead of HCG for to trigger the ovulation. So, in routine cases, we usually don't give estrogen because we usually uh, use HCG to trigger the ovulation. But in IRT cycles and some of the induction cycles where we are using GnRH agonist in triggering the ovulation, so there we have to use the estrogen if along with the progesterone. Now the third heading is programming of ART cycle. Now how the estrogen is important. Estradiol valrate is usually given as in a pre-treatment in GnRH agonist cycle to evaluate the efficacy of scheduling assisted reproductive cycles in a gonadotropin releasing hormone antagonist protocol through the flexible pretreatment with estradiol valrate during the luteofollicular transition period of the menstrual cycle. So, primary endpoint: proportion of patients undergoing the oocyte retrieval during the weekend days, which was significantly lower in the pre-treatment group compared with the control group, as you can see in the graph. So, pre-treatment with estradiol valrate results in a significant lower proportion of patients undergoing oocyte retrieval during a weekend day and can be valued tool for the organization of the assisted reproduction. Okay. So another thing, luteal estradiol pre-treatment coordinates follicular growth during the controlled oral hyperstimulation with GnRH antagonists. Now, our main objective to this study is to investigate whether the luteal estradiol E2 administration reduces the size discrepancies and enhances the ovarian response in recombinant FSH oblique GnRH antagonist protocol. So, luteal E2 administration reduces the pace of growth, improves the size, homogeneity of antral follicles on day 8 of recombinant FSH treatment and increases the number of follicles reaching maturation at once. So coordination of follicular development optimizes the ovarian response to recombinant FSH and oblique GnRH antagonist protocol and may constitute an attractive approach to improving their outcome. So pre-treatment with estrogen does not affect the IVF cycle. Estrogen does not affect the cycle's outcome and therefore might be used in a clinical practice for only programming IVF retrievals during the working days. So another heading is use of estrogen HRT prior to IVF in menopausal patients. So can hormone replacement therapy prior to oocyte donation cycle in women with premature ovarian failure improve pregnancy rate? So there are two groups. A group is 23 patients received HRT prior to oocyte donation cycle, and group B 23 patients went oocyte donation program directly after an artificial induction induced menstruation. The HRT group had a slightly higher pregnancy rate with a better mean endometrial thickness as compared to the non-HRT group. It was not statistically significant. The institution of hormone replacement therapy does improve the vascularization of the uterus and correct the histological features of the uterine lining and makes endometrium receptive. So this is how it is important. Now another heading. use of estrogen in prevention of adhesion formation, reformation after hysteroscopic adhesiolysis. So, hysteroscopic adhesiolysis is a safe and effective means to Asherman syndrome by dividing the adhesions and reconstructing the uterine cavity to normal. Most challenging problem is the management of moderate and severe intrauterine adhesion is the recurrence of adhesion, which is on average ranges from 3 to 24%. The prevention of adhesion formation prevention of adhesion deformation after hysteroscopic adhesiolysis. The 1964 Wood and Penna suggested use of estrogen therapy to stimulate regeneration of the endometrium after surgical treatment for intrauterine adhesions. The post-operative estrogen therapy has been widely used by many investigators to prevent the recurrence of the adhesion. So this is another use. Now, use of estrogen in clinical practice. The another heading is menopausal hormonal therapy. Now, what is basic of MST? It consists of a group of preparation with sex hormones administered in case of low estrogen. Estrogen replacement therapy for a woman with uterus and estrogen progesterone therapy for a woman with intact uterus. So with intact uterus, we give always progesterone with the estrogen. While there is no uterus, we only give estrogen for the MST. Now, how does it help? In improvement of vasomotor symptoms, this hormone therapy has been shown in the double-blind RCTs to relieve hot flushes and is improved as a first-line therapy for relief of menopausal symptoms in appropriate candidates. Now, another use is prevention of bone loss. So, hormone therapy has been shown in double-blind RCT to prevent the bone loss and in WHI to reduce the fracture in postmenopausal patients. Now, it helps in premature hypoestrogenism. Hormone therapy is approved for women with hypogonadism. Just a minute. हाँ क्या हुआ શું થયું અરે મોમને બતાવી દો 5 મિનિટ પછી મને મળો premature hypoestrogenism. Hormone therapy is approved for the woman with hypogonadism, POY, or premature surgical menopause without contraindications, with health benefits for menopause symptoms, prevention of bone loss, cognition, and mood issues, and in observational studies, heart disease. While in genitourinary symptoms, if the hormone therapy is shown in RCTs to effectively restore the genitourinary tract anatomy, increase superficial vaginal cells, reduces vaginal pH, and treat the symptoms of vulvovaginal atrophy. Now, what are the contraindications of MST? Unexplained vaginal bleeding. Sorry. I'm sorry. So, unexplained vaginal bleeding, severe active liver disease, prior estrogen sensitive breast or endometrial cancer, coronary artery disease, stroke, dementia, personal history of inherited high risk of thromboembolic disease, porphyria cutaneous carda, hypertriglyceridemia with concern that endometriosis might reactivate and migraine headaches may worsen or leiomas may worsen. So it is a primary active component of hormonal therapy and is the recognized gold standard for the treatment of menopausal symptoms, especially vasomotor. Systemic estrogen used for the hormonal estrogen therapy, hormonal menopausal therapy in India are conjugated equine estrogen and estradiol valerian. Now, conjugated equine estrogens, women using oral conjugated equine estrogens had more than twice the risk of venous thromboembolism observed in women during using oral estradiol. And CEE is a mixture of hormone derived from the horse urine and do not represent a replacement of natural human estrogen, such as 17 beta estradiol. It contains estradiol metabolites as well as equivalent metabolites specific to horses, besides the unidentified components of recognized recently. So, comparison. So these equivalent metabolites have toxic properties with the carcinogenic potential through the formation of quinones and semiquinones adducts with DNA. These equine hormones also contain androgens and several sex steroid of yet unknown vascular activity. It cannot be assumed that other HRT preparations like estradiol valate share the same potential for an increased associated breast cancer with long-term use. It seems more sensible to replace the estradiol deficiency by giving the exact hormone rather than the extract of uncertain composition, which is 100% correct. Now, this is a comparison of the this response in Indian menopausal women with different estrogen preparation for the treatment of menopausal symptoms. So, main aim of this randomized control trial is that the aims of the researchers were to compare the symptomatic responses in Indian menopausal women using different estrogen preparation for treatment of vasomotor symptoms and vaginal atrophy. Now, mean hot flash score over 24 weeks in the treatment, change in mean hot flash score over 24 weeks in different drug regimens, we can see in the graph that the red one, which is the most effective, it is estradiol valerate, E2V, right? And isoflavones are not at all effective, that we can see in the at the bottom line. So this is how we know, right? Also in this graph, we can see that the green line is of CEE, which is less effective than estradiol valerate, and placebo is more effective than isoflavones in this trial. So rather than giving placebo, rather than giving isoflavones, we can always give patients some other multivitamin drug or placebo to reduce the cost as well as to improve the drug. But the most effective is estradiol valerate, that is E2V. Now the another heading is use of estrogen in combined oral contraceptive pills. So mainly what component we use is ethylene estradiol. Predominant estrogen component used in last 5 decades is it. So EE enhances the contraceptive efficacy, helps in regulate bleeding, it is better oral bioavailability, it inhibits the FSH release and development of dominant follicle. Thus, it improves the cycle control by stabilizing endometrium and reducing the breakthrough bleeding. Now, reduction in estrogen dosage over time. High dose pill initially were having more than 50 microgram ethylene estradiol in the low dose pills are having 35 to 30 microgram, and now ultra low dose are having 20, 15 or 20 microgram. So let's get this comparison of high dose versus low dose. So WHO recommends the low dose pills versus high dose pill. International availability is also more with the low dose pill, and risk of MI is also less with the low dose pill, and stroke is also less with the low dose pill. So, of course, low dose pill is recommended and it is more effective with the lesser side effect. So, combined oral contraceptive pills containing 20 microgram EE may be theoretically safer, and data from existing randomized control trials are inadequate to detect the possible difference in contraceptive effectiveness. Now, low dose estrogen resulted in higher rates of bleeding pattern disruptions, and however, most trials compared to cirrhosis containing different progestin types and the changes in bleeding pattern could be related to the different progestin types. So, that is it for today. Thank you so much.
Ma'am, can you stop share the slide?
Yes, sure.
Thank you, ma'am. Thank you, Dhoni ma'am, for the lively talk in a very important topic. Thank you for being associated. Water Busman always stands committed in such kind of scientific feast. So in future also gives an opportunity to get connected, ma'am.
Thank you so much.
Thank you.